Assalamu alaikum. Before we start, if anyone wants to ask any question before regarding the previous discussion or any question, you are welcome. Anyone wants to ask any question? Okay. The topic which I want to discuss today is tetanus. Has anyone of you faced a patient with tetanus?
Yes, sir.
Okay. So what is tetanus, Asim, Dr. Asim?
The tetanus is basically gram-positive bacilli and caused by this tetanoplasmic Clostridium tetanus.
Asim bhai,
Gram-positive
I
bacilli.
have a request for you. There is a lot of background noise and echo. So if you can improve it, it will be you will be audible audible in a better way.
Yeah, because I'm on call, I'm in OR. Okay.
Okay,
So
okay. Just try to
I will
speak a
try it.
little
Okay.
louder. Just to avoid this background, you can just speak a little loud. Okay.
Okay. So tetanus is caused by powerful neurotoxin, tetanoplasmin. And this is produced by this Clostridium tetani, which is gram-positive bacilli. And this disease is characterized by a muscular spasm and rigidity.
Okay. What is what is the causative agent of tetanus?
This Clostridium tetani,
The
basically
Clostridium
gram-positive
tetani.
bacilli.
And
Yes.
they can ask you what sort of bacteria is this?
This is gram-positive bacilli.
Gram-positive spore forming.
Spore forming.
And it's anaerobe, right?
Yes, anaerobe.
Anaerobe. Okay. So okay. So what it does?
So basically, whenever there is a breach in the skin or mucosa, or there are a lot of like in the burn or in surgical any breach in the skin, like there is ulcer, gangrene, or like childbirth, abdominal or pelvic operations. So what it does is it goes. There is two type of this. There is one tetanolysine and tetanoplasmin. So tetanolysine is with the damaged viable tissues. There is the tetanolysine, and tetanoplasmin it went retrograde from that damaged tissue, travels by axon to the CNS.
Okay.
And
what it does?
It does. It went to the motor neuron cells and motor neuron endings, and there it does this rigidity and convergence and
Okay,
spasm of the muscles.
just stop it for a while. What is
Okay.
the basic cause for rigidity? Like what actually up till now we have discussed that this is a bacteria which is found in anaerobic conditions, and whenever there is infected wound, it can pass and it can grow. There is a incubation period. After that, it will create two sort of toxins. One is lysine. Lysine will create the dig through which the spasmin will go. Okay, and the name is telling actually lysine means it is causing lysis of the tissue, and the spasmin is the culprit. Okay.
Yes.
So what is the basic reason for rigidity? Like what is the basic reason for rigidity? Actually, if it is going up and it is blocking, there should be loss of power. So why it cause rigidity?
Because primarily it inhibits this glycine and GABA, this neurotransmitter. And what is done is because of this inhibition, there is the rigidity.
No, just be a little more clear in your answer. Answer is that the inhibitory control of the CNS is gone. Okay.
Okay.
It inhibits the inhibitory neurotransmitters.
Yes.
So wherever, like you can say that the control of the grandfather is gone. So everyone is angry. Okay. Everyone is fighting. Everyone, whosoever is touching anyone, he is fighting. Okay. I request all of you to mute your mask. My mask is now everywhere in our mouth. Please mute your mics. Okay. It's a humble request to all of you to mute your mic, please. Thank you. Yes, please. Okay. So this is the reason for the inhibition. Okay. Like, sorry, this is the reason for rigidity. So what will be the happening of the one selling point of tetanus is rigidity. What is the other dangerous most thing which is creating problem for us? One is rigidity. What will be the other thing?
The other thing is autonomic instability.
Very good. Okay. So these,
Yes.
if someone asks you, what are the problems related to tetanus to an anesthetist or ICU? Okay. So one thing is rigidity, because it is creating a problem in respiratory system. It is causing problem in controlling the airway. It is creating severe muscle spasms. And the other thing is autonomic dysfunction. Okay. So like what are the other clinical features when someone is asking you about tetanus, they would be asked, they will be looking to listen to the few words about tetanus.
Yeah. Yes. So they are tired of this diagnosis with muscle rigidity, muscle spasm, and autonomic instability. And with this one, there is two visible signs. One is facial muscle spasm with the rhizus sardonicus.
No.
And other is the arching of back, the truncal spasm.
No, truncal. Just a second. Yes, when you told about rhizus sardonicus, you should be telling the same because it's a nearby thing. It's lockjaw, trismus.
Yeah, lockjaw, trismus, yes.
And if you like, I will tell something funny. In the exam, the examiners look like rhizus sardonicus with no impression, no expression on there. It's very irritating thing. Nobody is understanding this thing. Please mute your mic, except the person with whom I'm asking. Anyone, all others can raise your hands to have any comment. But please, I will be very thankful to you that please mute your mic, and everyone is welcome to ask any question. Just raise the hands, and I will ask. Okay. So what I was telling, that if you want to recall this by the word, that in the exam, the examiner are looking very angry, and they have masked face. Okay. So they look like rhizus sardonicus. And because when you don't know how to answer, your jaw become locked. So it's trismus, lockjaw. Okay. And then when you are not able to answer the question and you are failed, then it becomes opisthotonus. So it's arch body. Okay. There is an animal which creates the body like that, which we find everywhere. What is that animal? Commonly, cat. Cat makes the body like that. So it's because of, what's the reason for opisthotonus, Dr. Asim?
Yes, sir.
Basically, there is a truncal spasm, and that is why there is arching of the back.
Okay. So there is a spasm of paravertebral muscles. Okay.
Okay.
So, and then what is the result of sympathetic overactivity? What can occur because of this sympathetic activity?
So there will be autonomic storm, like increase in catecholamine release with hypertension, tachycardia, and there will be more salivation, sweating, hyperparaxia. It all will be with this autonomic instability.
Okay.
We'll see.
Like any stimulus can cause spasm and So in this condition, the tetanus patient needs to be in a very quiet and calm environment. Okay. So what when we will be going, what will be the management for tetanus?
The management divided into three things. One is with the toxins which are releasing from the CNS. So we have to stop this one. And the another is the toxin present in the body outside the CNS. We have to give. And third thing is minimizing the effect of this toxin.
So
So
this is you
for
are talking about, just a second. This is you are talking for the disease. Okay, but when we are managing the patient, what this is not our first priority. What is our first priority in this patient?
So we'll go with the ABC.
Thank you very much. So you never buy. If you will be starting the answer with this thing, the examiner will be looking like you looking at you. Okay. So you have to first tell that my approach will be airway breathing circulation. I will try to have the control of airway. Okay. Because of like painful spasm, locked jaw, patient can have airway compromise. Okay. So this will be first approach. Then if you just divide it, that one thing will be to keep the patient quiet and calm and avoid any stimulus. This will be one. And the journal nursing care, which we discussed yesterday, fast hug. Okay. The feeding and whatever you want to say, it's there. And the other thing will be regarding to the disease. So what are the options which we have to give?
The option of management, you mean?
The which I interrupted you, the disease. The disease itself, what would you like to do?
Okay. For disease, I told you for three things. For further toxin release, we'll give antibiotics like metronidazole and benzyl penicillin, and it's early surgical debridement for this patient.
Okay. And what about the free toxin?
The free toxin, we have to give immunoglobulin for this phase because it is outside the CL.
Usually when we have a bruise or a cut wound, abrasion outside in a dirty environment, we go to the emergency and we receive an injection. What is that?
Yeah, tetanus toxide.
Is it tetanus toxide? Or it is another word which is being used for this is anti-tetanus serum. Am I right?
Okay, yes, anti-tetanus serum.
So what?
No, sir, no. This is not the serum.
Just a second. I just wanted to clarify. There are three things. One is tetanus immunoglobulins, one is anti-tetanus serum, and one is tetanus toxide. Okay.
Yeah.
Tetanus.
Go first time to the emergency.
Jamil, because I was just trapping Dr. Asim.
Sorry. Okay.
Yes, Dr. Asim. So
because we have to give tetanus toxide. This is the treatment.
No, that is not
initially. The prevention.
Yes. So now you are facing it. So you cannot give the prevention. Okay.
Yeah.
Or if you
want, we have to give immunoglobulin.
Immunoglobulin you will give if there is evidence of disease in the at-risk patient. But what you give it is anti-tetanus serum. Okay. With the injection which we receive is ATS. Okay.
And for prevention, which is tetanus toxide.
Tetanus toxide, which we receive at birth, which we give to a special group of patients in which there is high risk. Which is that one? What is that? Pregnant patient. To avoid maternal as well as tetanus neonatorum. Okay. And this is second thing. And if disease is occurred, then we are giving immunoglobulins. Okay. So they can ask you that what sort of immunity we are providing through immunoglobulins. Actually, this is to block
from the tetanus toxide. Yeah, it is active immunization for tetanus toxide.
Tetanus toxide is active immunization.
Yeah, and passive is from immunoglobulins.
Immunoglobulins. Okay, so this is the basic concept. So otherwise, we are just avoiding any sort of stimulus. So we can just keep the patient in a isolation. Okay, and dark room, avoiding totally knocked down. So what about the rigidity and spasm the patient develops? What are the treatment options for that?
Yeah, there is a specific with the benzodiazepines we will give with the midazolam infusion, and
Okay.
with morphine, analgesia or pethidine. Though
Okay.
pethidine is increasing the heart rate and all the thing, but it is written in the article we can give. And with propofol infusion also we can give
What
for
else?
this one, and anticonvulsants we will give.
Did you
And
mention? I just lost the concentration for a minute. Did you
yeah,
mention baclofen?
no,
Did you mention baclofen?
no,
Did you mention dantrolene?
no.
Okay, so sometimes they are needing high level things. Okay, so
Okay.
like we have to use baclofen or even dantrolene. Okay, other supportive
Okay.
will be magnesium, lidocaine.
Yes.
Okay, like all things which we use to have membrane stabilizing effect, and also magnesium cause relief from the spasms. Okay.
Yes.
And in addition to that, this was one problem which we're facing. Like if we are just compiling it, one is the cleaning of the wound and giving antibiotics, and giving either anti-ATS or immunoglobulin, or if the patient is not already immunized, giving immunization. This is one component. The other component is to give airway breathing circulation and support and all the nursing care. The other component is rigidity, which we have discussed, that we have to give some muscle relaxants. We have to give, maybe we require diazepam, dantrolene, baclofen, magnesium, different sort of things. Okay, and now come the autonomic. So for autonomic dysfunction, what options will be needing?
So autonomic we'll go with the short-acting beta blocker and with the HER2 agonist clonidine to inhibit the release of norepinephrine from pre-junction nerve endings.
So we like beta blockers, calcium channel blockers, esmolol. Okay.
Yes.
So, and the other thing which we discussed was feeding, like aspiration prophylaxis, analgesia, sedation, thromboprophylaxis, glycemic control. Okay, like journal care of care of any like what is that? Bed sores. Okay, prevention of
ulcer prophylaxis, glucose,
prevention of multi-organ failure. Okay, and then you will be needing in this patient early tracheostomy. Okay, sometimes it's unavoidable. So like this component, they can ask you in table viva, and you can have some MCQs about it. In our part of world, it's more common. So it's definitely being asked, and because it's not written in the common books, so sometimes we miss this question. Okay, so these are the maximum. They can ask you how much is the incubation period, like it can be from 3 to 4 days to even weeks. Okay, and like you just have to anything. Tayyaba, would you like to add something?
Sir, have we talked about the autoclave and in which temperature we would autoclave the instruments for this Clostridium tetani?
Actually, we would be discussing it separately in sterilization on autoclave, because the topic which we can add it to that discussion is actually Creutzfeldt-Jacobs disease. Okay, so we can have a separate discussion. I just focus on the disease pathology, the clinical features, and the main ICU or anesthesia challenges for a patient with tetanus. How it spreads, how it is presented, and how we manage it. Okay.
So classification of tetanus.
Yes, the severity, like you are talking about LB.
Grading, yes.
Yes.
The grading of tetanus.
So
LB
if you
grade.
remember, you can tell.
Yes, sir. So there are basically 4 grades: mild, moderate, severe, and very severe. Basically, we grade on the basis of respiratory symptoms and the dysphagia and trismus as well. Mild, moderate, and severe, there would be the mild, moderate, and severe trismus, and there would be no dysphagia in mild tetanus, but there would be respiratory involvement, mild dysphagia in moderate. In severe tetanus, there would be severe trismus, generalized spasticity, and two important things. One is the respiratory rate would be greater than 40 and heart rate would be greater than 120. And in very severe tetanus, there is a combination of two things. One is the grade 3, all the symptoms from the grade 3, and the autonomic instability. So
Okay.
these are the 4 grades.
Okay, so Tayyaba, I will just tell you that, for example, in the rush of exam tension, if you forget the exact things, at least do remember the main factors like you told in the start. Okay, like
Okay.
because not everyone will be able to recall all the gradings and severity. So for example, if you forget, you just have to mention, like in the start you said that you grade according to these symptoms. Okay, like it's mentioned
Okay.
here. Okay.
Yes, sir. Sir, I would also like to talk about the symptoms of the tetanus. I don't know, have we talked about this?
We have
That
talked.
how the tetanus affect on the CVS, CNS, and the
It's
renal
autonomic
function.
dysfunction, and we talked about opisthotonus, rhizus
Okay.
sardonicus, and
And there is,
lockjaw. Okay.
yes, and
Uh,
there is high output. There is basically the hyperdynamic circulation with the low intravascular volume. So there is a high output renal failure as well. There can
high
be
output renal
oliguria.
failure. What is that?
Yes. So it means that basically we have the hyperdynamic circulation in the body with the increased cardiac output and decreased SVR, but our kidney is failing just like the acute tubular necrosis. The mechanism is the same like acute tubular necrosis. It can be polyuric or oliguric failure of the kidneys.
Okay. 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 Fine. So, any other question? Anyone else want to add something?
Actually, it's not too much important for anesthesia,
Please.
but somebody asked about the neonatal tetanus, and I just explained him even that the tetanus injection means toxide for active immunity is given at the 7th month of pregnancy
Okay.
for the prevention of the neonatal tetanus. And if somebody came to emergency with dirty wound, then we have to ask about the previous immunization, means the previous injection. Until age of the 5, no need to give the toxoid injection. If less than 5 years before he got the injection.
Okay.
And if we from 5 to 7, then we have give one injection. If we have the last injection received before 10 years, we have give the 2 doses of this active immunity. And
Okay.
definitely it's not directly connected to our anesthesia department, but sometimes
Yes, you
there is
are
one
right, but
MCQ.
actually, yes, they can. It's actually least likely to be asked because this
Yeah.
is a separate topic and separate discussion.
Yeah,
Right?
actually, the last week I have seen one this ICU, MCQs during I reading ICU, and it was also new for me. Just want to share.
Okay. Thank you. Thank you. So, few words about the similarly. There is another condition which is related to actually also the same group, anaerobic, gram positive anaerobic. What is that? The same group of Clostridium. Do anyone remember this?
I think botulism.
Botulism.
Yes.
Okay. So, like, anyone knows about it?
I know the mechanism of action of a mechanism, the pathophysiology of that toxin botulism. As
Okay.
we talk about this tetanus, means the toxin, they work at the spinal cord level. and they inhibit means they destroy the inhibitory neurons. But the botulism, their pathophysiology is that the toxins, they don't release the vesicles to acetylcholine vesicle to excrete in the neuromuscular junction. That was there was flaccid paralysis during this botulism. But I know.
Yes, but like you see that's what I was telling at that time, that usually even if we think about tetanus, if we think about the pathology, maybe we can consider that there should be weakness there as well. But it's in botulism, actually the weakness occur because of the not availability of the neurotransmitters. Okay. So
The history will be different also, means the history of means
food
the ready
related.
food, junk, this tin pack food or honey or anything else, that was conserved for a long time, and is acute, within 24 to 72 hours. But the history of tetanus means the wound means the onset from days to weeks, but comparatively botulism is an acute onset within 24 or 72 hours.
Yes, and another thing is that the symptoms of there are neurological symptoms, okay, and usually in reverse situation to what we face in GB syndrome, there is descending paralysis.
Descending paralysis, yes.
Okay, there is descending paralysis, and if someone asks you that the same principle will be there, there will be some antibiotic, there will be some general care, respiratory failure will be there. So you will have to intubate the patient and the general nursing care. Okay. So if, for example, this question is by the way asked to you, no need to be worried. You don't need to have too much details. It comes in the differential diagnosis of muscle weakness in ICU. Okay. So like just like GB syndrome or myasthenia gravis aggravation or polio, like any encephalitis, it's one of the DD. Okay. And there will be some association from like on the basis of history, you will be able to pick it out, and maybe there will be some confirmation from food, like food passage. So you can maybe it will be on the stool culture or something like that. Like few words I just want to discuss. So our next target for today, what are the causes of muscle weakness in ICU? Who would like to tell? And please, up till now, if anyone wants to volunteer, okay, or okay. So yes, Dr. Same. Yes, Dr. Same, can you hear? You can unmute yourself and speak out.
Yeah, now is unmute.
Yes.
Okay, you are telling about myopathy in ICU, yeah?
Yes.
Okay, a lot of causes for myopathy in ICU, like corticosteroid injection,
okay,
like other diseases, rheumatological diseases like polymyalgia rheumatica, maybe fibromyalgia, maybe hypothyroidism or hyperthyroidism.
Okay, actually, myopathy is something like it's a part of it. What are the causes for muscle weakness? Okay, and how in ICU patient you will be like facing this muscle weakness? Okay, like it will be usually it will come in the form of fail to be weaned off. Okay, like patient you will not be able to wean off the patient, and then you will be going towards a differential diagnosis. You will try to rule out any residual anesthesia drug effects. You will see any residual neuromuscular blocking effect. You will rule out
electrolyte disturbance.
Yes. So what electrolyte can be the cause?
Maybe hypophosphatemia.
Hypophosphatemia. Okay.
Hypokalemia. Or hypomagnesemia.
Okay. What else?
What else? No, I don't know.
What about hypermagnesemia?
Mhm.
Okay, and then there may be some central neurological problem, like maybe patient has cerebral
Stroke.
insult, stroke. Okay,
Uh-huh. Mhm.
then the patient can have any neuromuscular disease which is aggravated now. Okay,
Mhm.
and it was not diagnosed, like GB syndrome, myasthenia gravis, there are
Heraldano.
yes, there are like we just discussed botulism.
Mhm.
Okay,
Mhm.
there will be a differential diagnosis, and
Very
if
big, yeah.
yes, and if you just rule out everything and you don't find anything, then you will go label it towards critical illness,
Mhm.
muscle weakness, like ICU acquired muscle weakness. Okay.
Mhm.
So
Mhm.
what are what are different presentation of ICU acquired muscle weakness?
You're asking me?
Yes, Tayyaba, if you want to take over, yes, please continue.
Yes. Thank you.
Tayyaba, please take over.
So you're talking about the symptoms of the ICU-acquired weakness?
No, I'd like we say we discussed that there is a patient who was in ICU, okay, and usually the presentation will be that we are trying to wean off the patient, and like for example, before the patient was in multi-organ failure, we settle down. Now minimal inotropes, minimum vasopressors, chest is better, okay, but still patient is we are not able to wean off, okay. So now you will rule out any residual neuromuscular blockers or any effects of anything, steroids, and you rule out, you did some tests, and then apparently there is no other cause. Okay, so then you label it as critical illness.
Critical illness.
Illness,
Neuropathy.
like it's a group of with little difference actually clinically. Okay,
Yeah.
all will be
As an ICU acquired weakness is
yes,
broad.
ICU acquired muscle weakness or ICU acquired weakness. Okay,
Yeah.
and then it will either be critical illness polyneuropathy, critical illness myopathy, okay, or critical illness neuromyopathy. Okay, so you will be able to diagnose, differentiate it through nerve conduction studies, through some of the clinical features will be a little
Yes,
bit
sir.
differentiating. Okay.
Yes. So basically, this is diagnosed and this is assessed on the base of exclusion criteria.
Yes.
We have no other we have no definitive diagnostic test for the ICU acquired weakness. We can only do the test to exclude, as you have mentioned earlier, that can be GB, myasthenia, Lambert Eaton, or any other electrolyte imbalance. So the weakness is investigated on the basis of exclusion for these diseases. So we can do some lab tests in which we will exclude the other causes, in which we can do electrolyte panel, in which we will do the inflammatory markers, creatine kinase, autoantibodies against as against the which is the anti-musk antibodies, anti-ganglioside antibodies, or the acetylcholinesterase against the antibodies,
Like
which are
specific
present in 80.
specific antibodies, and then which test would you like to do?
I would like to do first of all the CT scan and then the lumbar puncture to rule out the GB in order to see the albuminohistological cytological dissociation, and also the nerve conduction studies, which is important. I would like to do the nerve conduction studies to basically to see the critical illness myopathy or the myopathies or the neuropathies to diagnose between these two, and also the electromyography. I would also like to do the electromyography, and I have also read somewhere written that we can also do the muscle biopsies to exclude other diseases and the demyelination as well.
Okay, So actually there is some very complicated criteria for excluding it. But even if you are able to tell like this, this will be the maximum they will be asking you in this topic. It's a very complicated topic actually, because how to differentiate, like what will be different, how can you differentiate between like if it is neural involvement or myopathy?
Can you say, sir?
Like how will you be able to differentiate
Differential diagnose.
between like
Yeah.
neuropathy or myopathy?
Yeah, neuropathy, then we'll do the nerve conduction study, and there will be less amplitude during this investigation. Means
Like
the muscle bulk will be okay,
yes,
or the contraction with other means like maximum stimulus will be okay, but the conduction through the axon will be, you know, the weak, means the amplitude of that current that going through the axon during the nerve conduction study will be low.
okay. So and if you talk about myopathy, what will be happening? It will be actually muscle histology. Conduction will be normal.
Yeah, yeah, dystrophy or muscular atrophy. First of all, there will be decreased bulk of the muscle. This circumference of that muscle, which clinically shows. And second, in this patient, mostly they have low level of albumin and high level of CKMB.
CKMB or CKMM, not CKMB. CKMB is for
cardiac muscles.
Yes, so it will be CK, non-specific or CKMM. Okay.
CKMM, yeah, CK. Sorry, and there will be high level of CKM. And
okay.
The final diagnosis will be on muscle biopsy.
Muscle biopsy. Okay.
Yes.
So and there can be the funny thing is that there can be a combination of it as well. So
yeah. Most of the time,
actually, if you go to the bulk of the topic, actually the management is the same. You don't, if you are giving muscle relaxants too much, you have to just give them off the muscle relaxants and give some alternative. You just have to give time. If the patient is not having tracheostomy, you will go for tracheostomy. Okay.
Yeah, there is some in the treatment. Mostly there is to have to prevent the risk factors. Like you have to avoid the neuromuscular blocking agents. You have to minimum use of steroids. These are the most culprit that cause polyneuropathy and myopathies. Third one is hypo or hyperglycemia. Is most of the time happen during TPN or when the feed give in boluses. This is recommended that you have give a fixed volume of TPN, means 100 or 50 ml, not in bolus, because that one cause the hyper or hypoglycemia.
Okay, you talk about neuromuscular blockers. Any steroids
yes.
And some antibiotics like aminoglycosides.
Aminoglycosides, and try to reduce the time duration of mechanical ventilation less than 2 weeks. Try to do early tracheostomy and daily sedation break, physiotherapy, and what I already said.
Actually, then at this point of time, if you have reached up till there, you can say anything. Everything, whatever you are giving, the patient is, and there is no clear cut, like you cannot define it that you will give some medication and that the patient will be fine. Okay.
Yeah, but the most focus on the prevention of all these factors that cause polyneuropathy or myopathies.
Yes. So summary for this topic is that the patients who are in ICU for a long time and the primary pathology apparently is resolved, you have ruled out any other existence of any other disease by some investigations, like apparently you have treated everything, but still you are not able to wean off the patient. Okay. So now you will go towards your mind will be going towards ICU cord weakness. Okay. And the thing which you have to do is to try to maintain the homeostatic conditions. Like you have to maintain the electrolytes, you try not to give muscle relaxants, you try to maintain the glycemic control, you try to maintain the electrolytes, you try to have just pardon me for a second, please. I'm sorry. Yes, I received a call. So, so whenever like we will be targeting in that way. Okay. So general nursing care will be there, and all the nursing, all the things which we generally do in ICU will be. But Jamil, what will be the difference between parenteral nutrition versus enteral nutrition? Any association with it?
Enteral nutrition more physiological, and especially the parenteral nutrition also cause this polyneuropathy, myopathy. The reason is that during parenteral neuropathy, we are giving a glucose directly to the IV, and they told that the glucose by different mechanism of action, they can make in alpha glucose and beta glucose. They are mostly toxic, getting toxic radical from the plasma, and especially the oxygen radical, toxic radicals. And this is the alpha and beta glucose which destroy the small nerves, and there's further inflammatory radicals they will be excrete. And the second also, if we give the fat, in fatty acid also there is some toxic radical. They also injure the small vessels, very micro vessel in the nerve. Then the injury of that vessels means endothelium also cause trophical changes in the nerve, and at the same time that they can cause the trophical changes in the muscles. And what is the question then further also? Just guide me.
Just actually there is no specific. Just to repeat, I'm just repeating it, that either it is myopathy or neuropathy or combination. If there is any problem in the nerves, so nerve conduction will be delayed and muscle will be okay. And if there is myopathy, more symptoms on the muscles, and nerve conduction will be relatively fine. Okay, it can have combination, and you can have a destruction of the muscles. There can be some there can be presence of rhabdomyolysis, and some that's why the non-specific enzymes may be raised, creatine kinase, or picture like that one can be there if there is too much muscle loss. Okay, so this is so you just have to do glycemic control and feeding and whatever, because that's why that journal ICU care is so important, that you will bring, if you know that thing, that how to evaluate a patient ICU and how to manage a patient systematically in ICU, from airway, breathing, circulation, disability. You just you will be seeing whether the patient's airway is patent or you are giving support. So if you are giving support, you have to think about the ventilator VAP bundles. You have to try to have the oral decontamination. You have to give oral care. Okay, you just have to do the supraglottic suctioning. You have to try to you have to give some sedation breaks. Okay, you have to make head side up. You have to give some this one oral this one gastrointestinal tract decontamination through pneumycin. Okay, so these are I'm just we will discuss this topic separately, but I'm just giving you an idea, and then you go towards breathing or ventilation, so you are giving lung protective strategies. Okay, then comes the circulation. You are trying to maintain a good circulation. If you will be having a good check of the circulation by clinical parameters, by some invasive monitoring, by just even the touch of the patient. Patient is having cold peripheries or calm, good signs of good peripheral circulation. And then later on, you can have some cardiac output monitoring, CVP. Okay, even you can see the fluid status of the patient through focused ultrasound of vena cava, or like you can just have a simple test of fluid responsiveness through the leg raising. Okay, so then you will be going towards the neurological assessment of the neurological status. You can see with the Ramsey scale that what sort of sedation. And you, of course, you will only be able to see the level of sedation when you have off the sedation. Okay, and then gradually you will be looking at all the lines. You will be seeing whether the patient's blood pressure is maintaining spontaneously or you are giving some support. What are the ventilator settings? What sort of FiO2 you are giving? What sort of PO2 you are getting? Like how much you are investing and how good is the result is coming. Okay, then you are taking the intake output. Better to have the enteral route rather than parenteral route. Okay, even if you are giving parenteral, that the peripheral parenteral nutrition is better as compared to through CVP. Okay, because if you are giving through peripheral line, there are less complications as compared to if you are giving through the central line. Okay, this is actually the topic of nutrition we can discuss separately. If you are giving enteral nutrition, it is better, and then you have to keep the patient is in positive balance. Okay, because sorry, even balance. If you are giving too much positive, then it's also a cause of delayed weaning from the delayed. It can increase the ICU stay. Okay, and then you are maintaining all the homeostatic things. You are maintaining the blood. You are maintaining the this blood picture, the hemoglobin. You are looking at the white blood cell count. You are looking at the systemic inflammatory response in the form of ESR or CRP. You are sending cultures, urine culture, blood culture, sputum culture, and then you are adjusting your antibiotic according to it. You are maintaining the record of all the intake output, as I told you. So this is the general nursing care which you are giving, having the bed sores prophylaxis. You are giving some thromboprophylaxis. Okay, so just few words about it. So
yes, excuse me, sir. And Dr. Tayyib, she asked me about electromyography. I just want to add few words.
okay.
Nerve conduction study we do to rule out the polyneuropathy, and electromyography we just rule out the myopathies. The method how to do, there is two. One is simple method, just we check the force of that muscles. Okay, the other is we put some needle in the muscle and give some electric stimulus, then we see the contraction and force of that muscle. If the muscles force is okay, according to, there are some waves, it's definitely and the person who do, they know better, but they just evaluate how the force of that muscle. If it's in the normal range, they just exclude the myopathy.
Yes, actually the basic principle for it that then there will be neurophysiological study. Okay,
yeah,
the neurophysiological study either will be in the form of nerve conduction, or you are checking the muscles electrical activity, like you are checking the circuit, whether the bulb is fused or the wire is fused. Okay, if there is some problem in the wire, you will change the wire. If the wire is maybe bulb is not working, but actually the problem is in the wire is cut. Okay, so this is the concept. So you will do either, you will be directly stimulating the muscle, or doing muscle biopsy, or you can even do nerve biopsy. Okay, there, and then you can see the indirectly through creatine kinase or CSF. Okay, so actually this is a very open topic. You have a lot of margin to speak out, but you should be knowing the basic theory. It's exclusion diagnosis of usually exclusion. You rule out other diseases which can be the factor. You rule out other homeostatic conditions, homeostatic disturbance in the homeostatic condition, which is causing these problems. I'm not saying homeostatic, not hemostatic, because hemostatic is related to blood. Homeostatic is the environment of the body. Okay, it is actually occurring. It is a combination of all electrolyte, fluid, acid-base balance, and everything. Okay. So Tayyaba, are you clear? Yes, you want
Yes,
to
sir. I want to ask. Yes, sir, I want to ask two things more. Sir, one of our colleague has asked about the RSI in tetanus. As we all know that in tetanus patient there is sensitivity towards sucks. So and there is risk of aspiration as well. So there are two different things. So can there be an option of giving rocuronium in this patient if you want to do an RSI in the tetanus patients? So what's your remarks about this?
Then its name will not be rapid sequence induction.
وانا كنت بسمعه لما انت التسجيل وخلاص.
Its name will be modified rapid sequence induction. Okay, then it will not be called as rapid sequence induction. It will be called as modified rapid sequence induction, because they can ask you this question in a table viva. They can ask you this question even in talks. Okay, so difference between rapid sequence induction and modified rapid sequence induction. Rapid sequence induction with salic maneuver, pre-oxygenation, confirmation after you remove cricoid pressure before the loss of
cricoid pressure after
before loss of consciousness 10 Newton, after loss of consciousness 30 Newton. Okay,
30.
And you give the pre-calculated doses. Okay, and then you intubate the patient, and then you confirm it. Bilateral auscultation, tube fill the air, and then you remove the pressure. Okay, this is called as rapid sequence induction, and any change in this one is modified rapid sequence. Like if you are using rocuronium, high dose, intubating dose 1.2 milligram per kg, this is one modification. You are ventilating the patient with low airway pressures like less than 15, or this is another modification. Okay, so you can do it. The other, you see, in the setups where we have rocuronium, we actually, since last 10 years in Saudi Arabia, I have never used suxamethonium, by the way. I don't remember last time I used suxamethonium ever in my practice. There is no indication for using suxamethonium if you have sugammadex and rocuronium, and you have good gadgets. And you, actually, another thing, this is actually practical aspect, but if you do the RAM position, okay, so actually you are decreasing the chances of aspiration by making a reverse Trendelenburg. You are making the head side up, and actually if the pressure, intergastric pressure is increasing, it needs to go against the gravity. Am I right? So it needs more of the pressure to be generated in the intergastric area to deliver it, to cause the regurgitation. Okay, but if regurgitation do occur, immediately you have to do the head down and lateral and do the suctioning. Okay, if this occurs. So
the answer would be the use of rocuronium in the case of tetanus.
Yes, you see in the exam, don't take a chance. Just say that there is a problem with suxamethonium, because already there is lockjaw. Maybe you will not be able to intubate the patient. Okay, so you should go for this one, rocuronium. Yes, Ijaz, I totally agree with you. Actually, cricoid pressure is in my 17 years of career. I am saying this thing official, so it cannot be used in medical legal, I hope. But actually, I have never used cricoid pressure, and I hate cricoid pressure. And actually, cricoid pressure itself is not bad. The problem is the way we do it. Okay, because it's not being done by you; it's done by other person, and usually they are non-technical people. They are not able to. They are not able to perform it nicely. Okay, so that's the reason. But officially, if there is a patient at risk of aspiration and you don't do it, you are not covered medically. Okay, so actually, in the exam purposes, you have to tell everyone that you are doing. Don't proceed without cricoid pressure. But practically, I have never done it. I have never done it. Believe me, I have never done it in my practice. At least I can say for me, because the problem is that we are not doing it. Okay, there is a special device illumination. Yes, maybe you are absolutely right. Even they have said in during crash intubation, patient is collapsed. If you are facing problem, you can remove the cricoid pressure. So actually, cricoid pressure has a number of problems rather than goods. Thanks for mentioning it, Ijaz. Okay. So any other point regarding this
Yes,
discussion?
sir.
Yes.
Sir, one more point. One of our colleague has written about the VAB bundles. Sir, oral care with the chlorhexidine, there are two different things which, according to my understanding,
There are
one
two
is the
different things.
ventilator associated pneumonia care bundle and the ventilator care bundle. They are the two different things, because
How?
in the ventilator care bundle, we will use the PPI and we will use the we will use the PPIs. But in the ventilator associated pneumonia care bundle, we will use the PPIs only for the patients in the high risk group, because the use of PPI also expose the patient towards the ventilator associated pneumonia, isn't it?
I have no idea, please. And anyone else can add. Actually, you are all. Is there any other difference which you are telling?
Regarding PPI, now it's not the level 1 evidence that we have used every patient. It's level
Yes.
2B now the evidence that only if there is risk of the gastric ulcers or stress ulcer, then we will use.
Yes.
If
Yes.
you avoid all these things, PPA especially.
The rest of the things are the same. Okay, there is one supraglottic suctioning, there is one oral decontamination, there is one selective gastrointestinal tract decontamination. Okay, there is giving
Yes.
enteral nutrition via this one infusion rather than boluses. Okay, and use of prokinetic agent. These are the things which are common. Okay.
Okay. So he has also written about the antibiotics and VAB bundle. There is no role of antibiotics in VAB bundle, isn't it? Maybe I am wrong, but
no, about prophylactic, maybe is no prophylactic antibiotic to avoid the web. I think.
But there is no role of prophylactic antibiotic in any case.
No, antibiotic. You are absolutely right. The thing is that this thing which he has mentioned is something. I think he antibiotic. You are absolutely right. Thing is that if you are suspecting sepsis, what will you do?
Yes, then will be the antibiotics, but not it prophylactically.
No, it's not prophylactic. It's empirical.
Yeah, empirical.
It's
just
empirical.
The onset of the web. First within first 5 days or late web. According to that, you will use the antibiotic.
And listen. She is saying in a different way. I am telling in a different way. Like Nader, who has mentioned it, you are absolutely right. There is no role of prophylactic antibiotic. Okay.
Yeah.
But when we are talking about a patient overall, okay, if we are talking about ventilator associated pneumonia, still we have to give antibiotic according to the picture of the pneumonia, whether it is early onset or late onset, or this is one thing. The other thing is that if we have a patient with suspected sepsis with Q-SOFA more, what will you do? Would you wait for you have to start the antibiotic. So actually this practically speaking, have you seen any patient being treated in ICU without antibiotics? No.
But sir, I don't think so. This is a good practice of giving antibiotics in every patient.
I'm not disagreeing to your point. So in the exam, you will never say prophylactic antibiotic. Okay, like there is even if there is aspiration. If there is aspiration,
there is no role of antibiotics in aspiration as well.
That's what I'm saying. That even with aspiration, unless there is fecal aspiration, there is no role of antibiotic. Okay. So the thing is that you just are actually you are just twisting the words. You are not saying prophylactic, but actually the real window in which we don't have to use antibiotic is nothing. Practically speaking, I'm telling you that there is no window. You see, you are saying no role of prophylactic antibiotic, but you are saying yes, if there is VAP, you will do this. If there is Q-SOFA high, you will give antibiotic. So what is left? Just tell me. So actually, sometimes this medicine is just twisting our heads. Am I right? Okay.
Yes, sir.
So they like
even
in this point.
in ICU, most of the time they give the antibiotic to trauma patient also, or patient even with other disease.
No, but Jamil, she has a valid point. Unless there is indication, you will not give anything. Okay,
Yeah.
she's absolutely right. According to exam point of view, you will say this. Like for example, there is a scenario that if patient has negative pressure pulmonary edema, there is no indication of antibiotic.
Yeah.
No indication of steroids even. Okay, if the patient aspirated and there is no fecal matter, you will not give antibiotic.
No role of antibiotic. Yeah.
Okay, so but practically we do all the things which are wrong. Practically we do all the things which are wrong. Okay.
Yeah,
Okay, Nadir,
as you
get
told
the
us,
answer?
the answered early or the late, according to that, we know the pathogens of that, the period, then we can give the antibiotic. Other is gold standard, ball. Do the ball, and then according to its results, you can give the antibiotic. This
Yes,
is the
and ball, in which
alveolar
we will
lavage.
do the protected, protected brushing.
Just a second. For all the
ball is gold standard.
Listen. For the exam candidates, these abbreviations should be haram. Okay, never use abbreviations. He will
bronchoalveolar lavage. Actually, the people know.
He will twist you that I have not passed you, and how can you use the abbreviation? Abbreviations are only only halal after you pass FCPS. Okay, Jamil.
Okay, sir. I am still resident.
Okay, so
okay,
actually this was a very I hate this topic. Actually, I really hate this topic, but I have just recalled by discussing with you. So actually one more thing which is left is also a very terrible topic which I don't like, but we have to do it, is the muscular dystrophies. Okay, so what sort of different muscular dystrophies we can face? Have you heard of myotonic dystrophy?
Yes, sir.
Who would like to tell? Asim bhai, would you like to say something?
Yes, sir. So,
Okay.
what is the understanding about this? Dystrophies are congenital and acquired.
Just a second. Yeah. Tell me one thing. What is actually difference between myopathy and dystrophy?
Myopathy is with the muscle.
Then what is muscle dystrophy?
Dystrophy is dysfunction of the muscle.
Dysfunction of the muscle. So it can have spasm. Am I right?
Yeah.
So if you talk about myotonic dystrophy to start with.
So I am not understanding what can you repeat the question?
What is myotonic dystrophy?
Myotonic, there is myotonia basically. So there is two elements in the same disease.
Yes.
Yeah.
No. Actually, there are, because there are number of dystrophies. Okay. One will be related to electrolyte, like hyperkalemic or hypokalemic periodic paralysis. Okay. One will be because of some autosomal problems like Duchenne. For example, I'm using the common word, and one is myotonic dystrophy. Okay. So I started with myotonic dystrophy. Myotonic dystrophy is because, as the name is telling, there is myotonia and there is dystrophy. Okay. So it's a combination, as you told, that there are, apparently it looks a weird word, but it's there is a spasm. There is a spasm because of muscle relaxation does not occur in time after contraction. So any stimulus which is causing the muscle to have contraction but does not cause relaxation. Okay, so there is delayed muscle relaxation, and the problem is in the channels, ionic channels. So that's why that is resulting in contraction. Okay. Okay, so what are the features of myotonic dystrophy? Yes, Tayyiba, would you like to say something?
Yes, sir. So there are some important systemic manifestations of this disease because of this prolonged, as you have already told, prolonged contraction and inability of relaxation. This is the one feature of this disease, and other is the progressive weakness, which will lead to the muscular atrophy. So there are two words basically, myotonia and dystrophy. Yes, there are some systemic manifestations of this disease as very important on the cardiac. We can see the cardiac conduction defects on the heart, which will be in the case of increased QT interval and increased PR intervals, cardiomyopathies and mitral valve prolapse. It means you will have to fully evaluate the patient if you are taking care of the patient in the peri-op period or the pre-operative area. You will do the cardiac workup in a detailed manner. I will like to involve a cardiologist as well for this cardiac conduction abnormalities, because these are the serious one in these type of patients. Also about the respiratory manifestations, these patients show the restrictive pattern of respiratory mechanics. So PFTs and these things are also important in these patients. These patients also show the symptoms of the obstructive sleep apnea, hypoxemia, which can also lead to the cor pulmonale as well. So on this aspect, these patients will be examined thoroughly on the respiratory mechanics as well. And also some other autoimmune, as this is an autoimmune problem, other kind of disease like hypothyroidism and diabetes should also be ruled out in these type of patients, because there is a strong association of the hypothyroidism and the diabetes in these patients. And now coming towards the GI tract, which is also our concern, these patients shows a delayed gastric emptying. So there is a risk of aspiration in these patients. So this will be the one other area of concerns regarding our anesthetic concerns.
Is related to delayed gastric emptying, also related
Yes.
to the contracture which occurs. Aspiration, also because of the actually involvement of the bulbar muscles. Okay?
GI, yes, bulbar palsy as well. Yes.
And because sometimes Tayyaba, there will be not much time for you to tell everything, and another thing is that you can forget. Okay, so just as a backup, try to have simple small buzzwords so that you don't forget. Like in this one, you will have the like any there are in the problem in the conduction and failure. This is two things you can remember, and then you can make the story. Similarly, respiratory system, there is actually because of restrictive lung disease pattern. So there will be pulmonary hypertension and resulting in all the cor pulmonale and whatever it is occurring. Okay, and as we told that there is autoimmune disease, so there can be other autoimmune disease as well. Okay, so what you'll be taking care while anesthetizing such patients with a history of myotonic dystrophy, in addition to you will be optimizing. So remember one thing, when they will be asking you, try to not forget that this is like any other patient. So don't forget the general care which we have to tell in every patient. Okay, this is one thing which we can easily miss. Okay, so one thing is that the general things which are always there, don't forget about, related to surgery, related to that patient age group, related to that patient, any specific for example, any specific condition like obesity, like elderly, like pregnant patient, like age related anything. So don't forget to tell when, because when we are telling some specific disease, we can easily miss this simple thing. Okay, so you can always say whenever there is respiratory problem, you will say that you will try to optimize it. Any infections, precipitated infection, or patient is smoker, you have to tell that this is part of optimization. Okay, if there is any heart failure, you have to treat it unless it's an emergency. Okay, so this is a general thing which you can use in every giving anesthesia care to any patient, you can tell these words. Am I right?
Yes.
Okay. So what specific thing you don't forget in this patient?
Yes, sir. I would like to pre-optimize the patient, as I have already told about the clinical manifestation of the disease. So my optimization will be on the same points. One, I would be taking care of the bulbar problems, which is dysphagia and the risk of aspiration, the cardiac abnormalities, which I already told that the conduction defect, it may also need the involvement of the multidisciplinary approach. And about the respiratory mechanics, I would like to pre-optimize the patient, and if there is any risk of infection, I would like to cover this infection before giving the anesthesia. And if there is a risk of OSA, I would also like to involve the respiratory therapist, and also try to give the incentive spirometry or the non-invasive ventilation if the patient
Yes,
needs
this is
pre-operatively.
this you can tell a lot of things for optimization. Now come to the practical conduct. What things will be specifically in your mind? One is aspiration. Number two.
Number two is the aspiration on induction. You're talking about the investigation or the induction of the anesthesia?
No. Now practical, because this topic will be asked not in the long case. This will be you asked in table viva, okay? Or if the other people who are listening for their MCQs, the focus will be related to the problems related to it, like cardiac problems, respiratory problem. But practically in the conduct of anesthesia, most important thing, as you told, is and all the factors which can precipitate this
disease,
myotonia. Okay, so everything, hypothermia, succinylcholine, even dithermy, okay, shivering, okay, and
yes,
any other factor,
surgical stress,
and any other factor which can precipitate muscle problems like potassium, magnesium, calcium. Like these will be these can create increase in these problems. Okay, so you just have to avoid stress like that. Okay, so what would you like to use the tourniquet?
What is the contraindication of tourniquet? I don't think so. There's a contraindication of tourniquet of
That's what I'm
these
asking.
patients. Is there any?
If you have any
No,
doubt,
I can use, yeah.
Risk versus benefit. Like this, they can precipitate, like, but just like sickle cell disease. What you say is tourniquet contraindicated in sickle cell disease?
No, not contraindicated.
No.
This is
So
decided on the risk versus benefit.
If you have any doubt, for this is a standing instruction for you, for all of you, that if you have any doubt, you use this word, risk versus benefit. Okay, this can cause this problem, but if there are some advantages which you can get, so you will do it. Okay. Okay. What about the neuromuscular blockers? Can you give muscle relaxants?
Sir, preferably we should avoid these neuromuscular blockers, both the depolarizers and the non-depolarizing neuromuscular blockers. We can use another approach, which is, as you have already told, we can do the awake fiber optic, which I have made in my mind that the scenario regarding myotonia, I will do the awake fiber optic, and for maintenance, I would like to use Tiva on propofol and the remifentanil infusions without giving, and because if I would give the muscle relaxant at induction, the anticholinesterase also potentiate this problem, aggravate this problem. So I would like to avoid as much as I can.
Yes, you are right. You are absolutely right. Just like we talked about in myasthenia gravis, if you need to use it, you will use neuromuscular neuromuscular monitoring. And if it is deemed necessary, you try to use cisatracurium, which will be metabolized. You don't need to give reversal. You can use rocuronium because you can reverse it with sugamedex if it's available. So you can use these words. Okay. So basic principle is avoid the factors which can cause stimulation of the muscle contraction and related myotonias. Okay, so this is the basic theme, and you have to rule out cardiac, respiratory, and any end organ damage because of it. Okay, आसिम भाई अब clear हो गया ये? MH का इससे association नहीं है, Duchenne से है.
Yes sir, नहीं है.
जी सर, इस वजह से मैंने पूछा है कि कुछ जो न्यूरोमस्कुलर वो पूछती है ना उसमें
वो कुछ MCQ बुक्स में ऐसा लिखा है उन्होंने कि इसकी एसोसिएशन है, लेकिन ऐसा नहीं है.
On the international sorry forum, I forget about sorry.
Yeah, sorry for everyone. We try to speak in English, okay?
Yeah, sorry. Yes.
In some MCQs books, but you are saying Tayyaba?
Yes, sir. In some MCQs book, I have also in Rakesh Tandon. I don't know you would like this book or not, but I have read here that there is an there is an association. There is an association written in that book, but in other many books and in many articles I have read that there is no association.
Remember one thing, Tayyaba, regarding this thing. Actually, no book is good, no book is bad. There are so many mistakes. You will be surprised. When we studied, me and Jameel actually. We both did a European diploma in anesthesia exam, and when I was studying, believe me, I find so many mistakes in every book. Believe me that there is no book which is free of mistake. But usually there is one Baba which usually doesn't do the mistake. That is Google Baba. Okay, so whenever you have any doubt, I will be very straight in telling you that there can be mistake in anything. Okay, so don't trust any word unless you confirm it. That's how you learn. Maybe it will take some time, but the knowledge which you will get after reconfirmation, believe me, you will be surprised. Okay, someone asked me today that myasthenia gravis, is there any autonomic dysfunction or no? So for a few minutes, few seconds, I got confused that, oh, myasthenia gravis, is there any involvement of autonomic system or not? Then I Google it and I found the answer that there is association with autonomic dysfunction, and then I sent the reference. Okay, so similarly, don't trust one book, one word, because your knowledge, your intelligence is much better than a word written in any book. Okay, because at this stage you can find mistake in anything, I tell you. Okay, so this is my suggestion to everyone, that try to reconfirm. If you have any like competition between your concept, basic concept, and something written in the book, do confirm it. By the way, Rakesh Tandon is good book, but there can be a mistake.
There are some mistakes. Yes, sir. There are some mistakes in that book too. Sir, I would like to add something, and I would like to ask something from you. The risk of aspiration. Whenever there is a risk of aspiration, whenever there is an autonomic instability, and I am concerning about the risk of aspiration, and I can't use sucks as in the case of tetanus or the myotonic dystrophies. So what would I do? In my head, I have made a scenario of these things, and my conclusion is I would be going with the awake fiber optic in a very cool and calm environment, like in OT, not in the emergency case. In an OT, I would do the awake fiber optic. But about the blocks, if I would recall all the blocks, they also increase the transtracheal block or all the superior recurrent superior.
Can you, because you have to differentiate between different categories of autonomic problem. Okay, if you are talking about diabetes,
I am talking about only the risk of aspiration. No, I am only concerned about the risk of aspiration here.
Risk of aspiration,
and I can't use sucks.
No. Just tell me one thing. What will be the probable scenarios if you are talking about pediatric age group?
No, I am talking about this myotonic dystrophy.
Let's
take this one.
Okay, so you would not like to give succinylcholine in this patient. So your question is what you would like to give.
Yeah.
So what about giving rocuronium? What's the issue with giving rocuronium?
If someone says, have you ever used rocuronium?
No. This is remember one thing. You can actually, it's available in Hamid Latif. So you don't have any escape. You can say that I have used it. Okay. All
Okay,
will
sir.
get done.
Okay,
If you
okay.
have any problem, you can say, you see, confidence will tell you, I'll tell everything. Okay. You can say that, yes, I have not used it, but I have read about it. So, of course, if then he can catch you that if sucronium is not available or sugammadex is not available, what will you do then? Yeah, the answer problem will start here. Okay. So
No,
actually,
now tell me the consequences of the awake fiber optic in the case of the risk of aspiration, as I have read today, that this is an indication, the risk of aspiration is an indication for awake fiber optic. But my concern is awake fiber optic can increase the risk of aspiration, isn't it?
mm, how? How?
If you block the nerves, which are the protective nerves, you can use then awake fiber optic without the blocks, without any. If you give a sedation, you have to give a sedation to the patient, some little sedation or the titrated sedation if the patient aspirates in that sedation, because we don't know how the patient reacts with this sedation, with this little amount of sedation.
Usually, you have a valid point. You have a valid point. That's why I'm telling you that practically what we do, if for instance you forget it, okay, you can just tell that this is a challenging situation. There are problems associated with even with awake fiber optic. There are problems associated with succinylcholine. There are problems associated with the other muscle relaxant. You have to make a risk versus benefit. Whatever you are doing, what is safe? Just tell me. What is safe? Nothing is safe.
Rocronium, in these three, rocronium is safer than all other two.
Dexamethasone, okay? Because rocronium, if you are giving, you have sugammadex and you give rocronium and you give inhalational agent and then you intubate it, okay? And you make a RAM position, you give acid prophylaxis. You can say like this. Actually, there is no clear-cut answer for this question. This is one option.
Okay.
Actually not, you don't block subglottic area, do you? When you do awake fiber optic, do you block the subglottic area?
Then what's the transtracheal block?
No. Just tell me one thing. When we are doing awake fiber optic, do we block subglottic area or no?
Probably no.
So cuff reflex is not fully gone. Okay. So actually, you can say that in when you are doing awake fiber optic, still there can be aspiration. Okay, but the chances will be less as compared to if you are giving inhalational induction. Okay.
Yes.
Or you are giving muscle relaxant. If you have given muscle relaxant, the chances of aspiration will be more. Okay, because cuff reflex will be gone. There is no muscle activity. Okay, so if you are doing only nerve blocks for tracheostomy, awake fiber optic, mainly your focus is supraglottic, not subglottic. Okay, even in transtracheal, where you inject?
In the cricothyroid membrane.
So is it supraglottic or subglottic?
The supraglottic.
Thank you very much. I hope you understand the answer.
Yes.
Okay, so because
yes.
I told you that every day there is nothing is safe. Only safe is mom's lap. Nothing else is safe. Okay, nothing else is safe. If you keep the baby or if you keep the patient in his or her mom's lap, only that place is safest in the world. Nothing else. Whenever the patient is with any doctor, he will be playing with it. Okay.
Yes, sir.
Risk versus benefit everywhere.
Risk versus benefit. For exam purpose,
yes.
Risk versus benefit. Okay. So actually, I'm telling you that, believe me, they will not go so far, Tayyaba. This is one of the most difficult topics, I tell you. I always feel myself regurgitation whenever I read this topic, believe me. So I don't think so. They will go so deep. You just have the basic concept. You just have to defend whatever you are doing. You should have a reason for whatever you are doing. Okay. So actually, some of the dystrophies are left. And who would like to tell about Duchenne? Asim bhai, would you like to say something about Duchenne? Yes, anyone? Asim bhai is here or he is busy? Yes, Asim, Dr. Asim, can you hear us? Okay, so some word about Duchenne muscular dystrophy. What is it? Yes, Tayyiba, you can continue.
So this is a very difficult topic, seriously. Duchenne muscular dystrophy, this is also an inherited disease as the myotonic dystrophy. Myotonic dystrophy was the autosomal dominant, and this is the X-linked recessive disorder. This is also the restrictive lung disease. I would tell whichever comes into my mind.
Remember, yes,
and the cardiomyopathy.
Same thing.
The risk of cardiomyopathy as well.
Yes, please.
The concerns are the same which we have already discussed about the myotonic dystrophy.
But which will
so
be
the risk of cardiomyopathy restricted.
What will be the difference? That here there are chances association with malignant hyperthermia. This is one thing. Okay, and the other thing will be there is more of weakness rather than spasm.
Yes, sir.
Am I right?
Yes.
So there is more of weakness. So if they will be asking you, maybe they can remember the basic thing. Remember that for any muscular dystrophy, you just have to think that what are the possible involvements. Okay, because there are so many details. There is Becker's muscular dystrophy. There is so many terrible dystrophies. Okay, but basic thing, remember, there can be involvement in the cardiac. There can be involvement in the muscle weakness, which will be presenting it either in bulbar or respiratory. This is common. Okay, so you can use the same things here. The only thing they has association with malignant hyperthermia. So any muscular dystrophy, how would you evaluate the patient, and how can you optimize? The same things. Believe me. Any sign of respiratory problem, any cardiac problem, any signs of cardiac failure, okay, and any previous history, okay, these will be the things which you will be asking. Okay, and regarding dexamethasone and volatile anesthetics, remember one thing, that even first exposure does not guarantee that there cannot be another. First anesthesia is uneventful doesn't mean that there cannot be hypothermia in second. Okay, so
yes, sir.
TIVA, you will be using TIVA. Okay, you will be using TIVA, and the rest of the things will be according. Of course, you will these patients will not be in a normal scenario. Okay, usually they will be asking you that. Usually, these will be child. Okay. So these will be children. So you will have to tell that the concerns related to altered physiological, pharmacological, and anatomical considerations. Okay. So whenever there is muscle problem, what can be the other consequences which can occur? One is cardiac, one is muscle weakness. Muscle weakness, have you heard of scoliosis? Secondary scoliosis.
Yes, sir.
Okay.
Yes, sir.
It can be scoliosis because of it. So concerns will be related to that thing as well. If this baby might have recurrent chest infections because of weakness, unable to cough, stasis. Whenever there will be stasis, the same concern will be in cerebral palsy. Same thing, almost the same things. Okay. If the baby, if not baby, if he has reached up to the adult age, then there will be chances of thromboembolism. Okay, babies usually the chances of thromboembolism is less. Okay, So the same basic principle will be applied. And like you can discuss with the physician, you can discuss with the cardiology consultation, and echo will be warranted because there is association with the cardiac abnormality. Okay, but symptoms will tell you, signs will tell you whether this patient, where does this patient fall. Okay, so whenever this such problem, you can say that I need to have intra-arterial blood pressure monitoring or cardiac output monitoring if it is if the scenario is requiring. So these are the basic things which you can say. Because of the the other markers of muscle lysis or muscle dysfunction will always be there. Am I right? Creatinine kinase will come here. Whenever there is like things like that, the common things will be there. There can be raised CRP, there can be raised ESR. Okay.
Yes, sir.
So as I told you, muscular rhabdomyolysis can occur in these patients. Okay, so this is the basic principle, and then there are some paralysis in other than the Duchenne, which are related to like hyperkalemic periodic paralysis and hypokalemic periodic paralysis. This is least likely to be asked, but if they ask, this is related to some abnormal channels. Am I right? I don't have much of the concept about it. Anyone would like to add to this boring topic? Anyone want to add to this beautiful boring topic? Okay, so we have tried to cover. I will just sum up. Most of the people who are here now with us, some of them have not attended our first lecture because that was in our language. Okay, but that was related to neuromuscular junction and the neuromuscular monitoring. Then we discussed about myasthenia gravis, Eaton-Lambert myasthenic syndrome. We discussed about GP syndrome. We discussed about tetanus. And in between, we jumped to some general ICU care. Okay, and then today we also discuss ICU acquired weakness. Okay, and at the end, muscular dystrophy. So I think we will finish here today, and we will start with some other system. Nadir, would you like to say something?
Oh, sir. Thank you, sir.
Yes, Nadir, your system, like you have a lot of noise, unfortunately, but you can ask even after we finish, you can ask anything. Okay, so we will be starting some new system. Okay, so as a summary, I would say to everyone that the topic specifically, because some of the people who are on the verge of passing our fellowship exam, like Dr. Tayyaba, Rabia today was not available. Jamil is appearing in the exam soon. So actually, if I just summarize this neuromuscular system which we have discussed, in OSCE exam in our TOEIC exam, they can have a station on the neuromuscular monitoring. Okay, so in neuromuscular monitoring, you should be knowing how to do it, where to do it, when we did say that patient intubating conditions are achieved. Like we discuss what muscles will be going first and what will be the last muscle to go, and then we say what is supramaximal stimulus. Like we say, usually we use train of 4, okay, to see whether the patient has achieved the intubating conditions. For in maintenance, usually we do, if we want to see the intense blockade, we do post tetanic count, okay, and double burst suppression we can also use. In the recovery, we again use train of 4, and then we will, so this is one of the questions which they can ask you. They can show you the basic difference between depolarizing and non-depolarizing. It is in the form of fading. So they can show you a graph, a picture, which you will be showing, and you will have to differentiate. We also discuss about dexamethasone, so they can ask you in OSCE as well this sex apnea. Okay, so what is the role of Dubocane number in it, and how you manage it? Like you will just wait and ventilate, counseling of the patient attendant, shifting to the ICU, plasma FFPs, and then ultimately it will recover. Okay, in that time you will just give the supportive care. So this is one of the topic which can be asked. Okay, then they can ask you this myasthenia gravis. Myasthenia gravis is the topic which is being asked. This muscular dystrophies, they can ask you. ICU-acquired muscle weakness, which we have discussed today, is a frequently asked question. Tetanus, they can ask you. Okay, so just mentally prepare any disease when they ask you. Just don't try to explain in very sophisticated words. Just try to explain what is it. Like tetanus, you can say that it is because of Clostridium tetanus, which is causing inhibitory loss of the inhibitory control. There is tetanolysin and tetanospasmin, and ultimate result is what? There is loss of the grandfather control, and there is severe rigidity. So this is one thing, and the other thing is autonomic dysfunction. So if you answer in that way, you will not miss the important points. Similarly, myasthenia gravis, you say that it is a muscle weakness because of postsynaptic acetylcholine, destruction of the postsynaptic acetylcholine receptor, resulting in muscle weakness. The area of interest for us is bulbar weakness and the respiratory muscle weakness. Okay, and the other thing which is important for us is the altered response to our commonly used neuromuscular blocking agents. So this is the main problem. Okay, and the autoimmune disease has so association with other autoimmune disease, use of role of immunosuppressants and steroids. So mainly whatever you will be discussing will be focusing around this thing. So bulbar weakness, respiratory muscle weakness, and you have some features which we already discussed. You can listen to the recording. It's available in YouTube, so you can see listen to it. I'm just trying to summarize whatever we have discussed. Then we discuss something. So this is the main thing which you will be focusing. They can ask you about ICE-PAC test. This is a very terrible question which is very famous in our Pakistan exam. So ICE-PAC test is actually when we put cold ICE-PAC on the eyes, anticholinesterase, this acetylcholinesterase enzyme, which is breaking down the acetylcholine is actually blocked. Okay, so because of the low temperature. So destruction of acetylcholine will be decreased momentarily for some time, and there will be increase in ophthalmic symptoms. I don't know why this question is being asked, but even I was asked this question in my table viva, so I can never forget this question. This very beautiful question, which has nothing to do with us. Tensilon test they also ask. GB syndrome we discussed day before yesterday. All the clinical diagnosis, ascending paralysis, and the role of immunoglobulins, plasmapheresis, some variants, AMAN, AMSAN, AIDP, Miller-Fisher, okay? And then we discuss about the whole journal features, respiratory support, autonomic problems. So autonomic problem, autonomic problem, autonomic problem. Sudden bradycardia, sudden tachycardia, sudden hypertension, position change, even position change should be very careful. Early tracheostomy and the supportive care, nothing specific, okay? And rest of the topic we discussed today. So I think it is enough for today. And thanks all of you to join us. And we will be meeting again with some new topic, okay? All of you are welcome to ask any question anytime. Spread the message to everyone. Please come out of the tunnel vision which you get from reading one book. One book is never the solution to our concept. Until the time we don't have the concept, we will not be able to perform nicely. Maybe we can slip one day, but we can slip other day. But at the end of the day, when you are dealing with the patients, you will be stuck and you will be embarrassed. Or another embarrassing situation is when some of your colleague, junior colleague, who is expecting, oh, my dear, you have passed the exam. So he or she will be expecting a very beautiful answer. And if you are not clear in your concept, believe me, you will be embarrassed. And this embarrassment will be big time. Because if you are insensitive, you don't care, you can dodge, okay? Like I dodge you people as well. Whenever I don't know something, I pass it to others because I'm not preparing it. I just sometimes open some of the source, but actually I'm not reading it. It's very difficult to read at this time of your life, okay? So, okay, ji, thank you very much, all of you. Bye-bye.